The Medicare Advantage lie that will cost you $50,000 in hidden fees. Sarah picked a $0 premium plan and saved $200 a month until she got cancer. Prior auth dragged 3 weeks, her surgery slipped, and by month 4 she hit her plan's out-of-pocket max. Then January 1 reset the counter to 0 while she was still in treatment. 0 premium didn't protect her, usage did the damage. 0 premium Medicare Advantage can still cost you $50,000, usually right when you're sickest. The ads feel friendly, the perks look helpful, and the premiums look like a bargain until the bills, denials, and delays start stacking up. It's not your fault, this system is built to confuse you. In this video, I'll expose the exact traps that create those hidden costs and give you 3 simple moves to avoid or escape them. We'll talk networks, prior authorization delays, and the out-of-pocket math nobody explains. Stay with me. Move 3 is the one your agent hopes you never hear. First, what Advantage really is. What Medicare Advantage really is, not Medicare but better. Here's the truth most people miss. Medicare Advantage is Medicare with extras. It's a private insurance plan that replaces Original Medicare for your medical coverage. The card changes, the rules change, and the way you get care changes. That matters because one wrong assumption can lock you into networks, approvals, and costs you didn't see coming, especially when you actually need care. Why does this matter so much? Because the decision you make at enrollment determines access later. When something serious happens, cancer workup, heart procedure, complex surgery, you don't want your options narrowed by a list you've never seen or a rule you've never heard of. If you remember nothing else, remember this: with Advantage, the insurer's rules come first. What is Medicare Advantage exactly? It's Medicare Part C, a bundled plan from a private insurer that provides your Part A and Part B benefits, and usually Part D drug coverage. Medicare pays the plan a fixed amount each month to manage your care. In exchange, the plan sets networks, requires prior authorization for many services, and determines copays and coinsurance. With Original Medicare, you can see any provider that accepts Medicare, and there's no network. With Advantage, it's their network, their process. The thing that trips people up is the shiny extras. Dental cleanings, eyeglasses, gym memberships, over-the-counter cards, those are the headline perks. They feel useful because they're tangible. But the big dollars sit in hospital stays, imaging, procedures, specialists, and post-acute care. The coupon book doesn't help when you need an MRI approved, a surgeon who's out of network, or skilled nursing days that require extra sign-offs. The cost hides in usage. Let me give you a simple mental model that makes this click. You traded any doctor freedom for coupon book perks and an annual out-of-pocket cap. That cap can be helpful for some, but the path to care goes through the plan's gate. Original Medicare plus a Medigap plan is built for access and predictability. Advantage is built for managed access with extras. Neither is good or bad in a vacuum. It's about what you value and what you'll likely need. Now, how does the bait work? 0 or low premiums feel like you're saving money. Many Advantage plans advertise premiums, and that's real. But premiums are just one line item. Advantage plans use copays and coinsurance for services, plus rules like prior authorization to control spending. For routine care, you might pay little. When care gets complex, those copays stack, and you can hit your plan's maximum out-of-pocket for Part A and B services within months. The premium didn't get you, the usage did. A common misconception is that your red, white, and blue Medicare card still works the same under Advantage. It doesn't. You'll present your plan's card, follow its referral and authorization rules, and use its network. If your doctor participates now, great, but networks change every year. Plans can drop hospitals, specialists, or rehab facilities. That's why people get blindsided mid-treatment. Here's where people mess up. They check if the hospital is in network and stop there. But care isn't just a building. It's your surgeon, anesthesiologist, radiologist, rehab facility, and the specialty clinic you might need if a complication pops up. In Advantage, each of those can be different providers with different contracts. One missing contract can move you from covered to expensive fast. This clicked for me when a viewer said, "My plan covered the surgery, but the specialist I needed afterward wasn't in network, and the plan wouldn't approve an out-of-network exception." That's the real-world impact of choosing a product that runs on insurer rules rather than broad federal access. Let me show you exactly how to avoid the first trap. Before enrolling, list your actual doctors by name and national provider identifier, not just the practice name. Confirm each provider and your preferred hospitals in the plan's directory, then call the office to verify they accept that exact plan. Ask about prior authorization for services you already use, imaging, infusions, injections, or durable medical equipment. If the answers are fuzzy, that's a red flag. Now, why is this better than just comparing premiums and perks? Because it aligns your decision with how you actually use care. The thing most people miss is that networks and authorizations control access. Perks don't fix a denial. A low premium doesn't unlock a specialist. You need clear proof that your care team and likely services fit the plan's rules. Common mistakes to avoid. Assuming same as Medicare means same access. Advantage replaces Original Medicare's rules with the insurer's rules. Believing our hospital is covered equals all your providers are covered. It doesn't. Forgetting that plans, networks, and copays change every year. What fits this year can break next year. Ignoring prior authorization. If you rely on scans, specialist procedures, or post-acute care, approvals are a big deal. Quick win you can do today: pull your plan's summary of benefits and evidence of coverage. Find the prior authorization list, specialist copays, inpatient daily copays, and the maximum out-of-pocket for Part A and B services. Circle anything you already use. If you can't find these easily, that's telling. Once you see what you traded access for a managed package, the next piece makes sense: the network trap, your doctor versus their list. Quick contrast you can use to orient your choice. Original Medicare plus Medigap, any doctor or hospital that accepts Medicare, broad access without networks, and for most Part B services, no prior authorization. Medigap caps your costs without a yearly reset on access. Medicare Advantage, the insurers network, their prior authorization list, and their timelines. You get a yearly out-of-pocket cap, but the path to care runs through approvals and resets every January. Quick contrast you can use to orient your choice. Original Medicare plus Medigap, any doctor or hospital that accepts Medicare, no networks, and for most Part B services, no prior authorization. Medigap caps your costs without a yearly reset on access. Medicare Advantage, the insurers network, their prior authorization list, and their timelines. You get a yearly out-of-pocket cap, but it resets every January and the path to care goes through approvals. The network trap, your doctor versus their list. Now the network trap. This is where good people get burned because it's invisible until you need something specific. Advantage plans run on contracted networks. That means the plan decides which doctors, hospitals, imaging centers, rehab facilities, and specialists are in. Everything else is out, or at best, covered at a much higher cost. With Original Medicare, any provider who takes Medicare is an option. With Advantage, it's their list. Why this matters: when care gets complex, you need specific names, not just categories. It's not a cardiologist. It's Dr. Patel who runs the clinic that actually handles your type of arrhythmia. It's not a cancer center. It's the one with the tumor board that matches your mutation to the right therapy. In Advantage, those exact names might not be in network, or access might be limited to certain departments only. Here's where most people mess up. They verify a hospital and assume all doctors there are covered. Not true. Surgeons, anesthesiologists, radiologists, pathologists, and rehab staff often bill separately and have different contracts. Your surgeon can be in network while the anesthesiologist is. That one mismatch can turn a planned copay into a painful bill. And if a complication forces a consult from an out-of-network subspecialist, your costs can spike overnight. The game changer nobody talks about is how often top-tier specialty centers are out-of-network or require special referrals that hit roadblocks. Heart programs, transplant teams, comprehensive cancer centers, these are exactly where you want freedom. Plans know these centers are expensive, so access can be tightly controlled. Even when the hospital is listed, the specific clinic or physician group you need might be excluded. Let me show you exactly how this bites in real life. You're approved for an in-network surgery. During recovery, a complication shows up that needs a specialized interventional radiologist. Yours isn't in-network. Your surgeon requests an exception. The plan says, we have an in-network alternative, but it's across town with the next opening in 3 weeks. Now you're choosing between delay, which risks your health, or paying out-of-network rates. That's the network trap in action. A quick win that saves headaches. Verify providers by NPI, the National Provider Identifier, not just the practice name. Practices can have mixed contracts where some clinicians are in, others are out. Ask your doctor's office to confirm the exact plan name and the specific NPI they bill under for your services. If you hear "we think so," push for a yes or no answer in writing through the patient portal. Another hidden snag, facility type. You might be cleared at an in-network hospital but end up receiving care in a hospital-based outpatient department with different billing rules, or you're redirected to an affiliated surgery center that isn't contracted with your plan. Before a procedure, ask, which facility and is that facility in-network for my exact plan? Then ask, are the assisting professionals and ancillary providers in-network too? Now, once you nail that, everything else clicks. You realize that coverage isn't binary, it's layered. There's the plan, the facility, the attending physician, the anesthesia group, the radiology group, the rehab or home health agency that takes over after discharge. One weak link and you're exposed. That's why you need to check coverage for the whole chain of care you're likely to use. The thing most people miss is that networks change mid-year. Providers renegotiate contracts, switch affiliations, or drop plans over reimbursement issues. Your doctor today may not be your doctor in 6 months, so you need a cadence. Every 6 months, call your key providers and ask, are you still in network for my plan by NPI? Any changes coming? If there's uncertainty, line up a backup in-network provider now, not during a crisis. Common mistakes to avoid. Trusting a plan's online directory without confirming with the provider. Directories go out of date fast. Assuming covered hospital equals covered surgeon. Always verify the individual. Forgetting post-acute care. Skilled nursing facilities, inpatient rehab, and home health agencies have their own networks and pre-approval rules. Ignoring travel. If you split time across states, your out-of-area access can shrink to urgent and emergency only, not routine specialist care. Here's the shortcut nobody teaches. Map your likely care path. If you have a heart condition, list cardiology clinic, imaging center, cath lab, hospital, and rehab. If you manage cancer risk, list oncology clinic, infusion center, genetic counselor, and second opinion center. Verify each node by NPI for your exact plan. If 2 or more nodes fail, that plan is a no. Now, before we continue, you need to understand the gate that sits on top of networks, prior authorization. Even when everyone's in network, an insurer can still slow or block care. That's the next obstacle, and it's where delays turn into dollars and health risks if you're not proactive. Prior authorization, delays that cost health and money. Even when every provider is in network, there's still a gatekeeper, prior authorization. This is the insurer's requirement to approve many tests, treatments, procedures, and medications before you can get them. The reason this matters is simple. Delays here don't just frustrate you, they can worsen outcomes and raise your costs later. A needed MRI that takes weeks to approve can stretch pain, postpone diagnosis, and push you toward the ER. And here's the kicker, those emergency visits and complications often cost you more out of pocket. According to physician surveys, 94% of doctors say prior authorization delays necessary care, and 1 in 3 report serious adverse events tied to those delays. That's not noise, that's risk. What is prior authorization in plain English? It's pre-approval. Your doctor orders something, an MRI, an infusion, a rehab stay, and the plan says, send us proof it's necessary. That triggers forms, clinical notes, criteria checks, and sometimes step therapy where you must try a cheaper option first. In Original Medicare, only a limited set of services need prior authorization. In Medicare Advantage, most enrollees face it for higher cost services like hospital stays, skilled nursing, advanced imaging, and cancer treatments. The thing most people miss is that a denial isn't always final, it's often a process. First comes a delay while the plan reviews. If they deny, your doctor can request a peer-to-peer review where a plan clinician discusses the case with your doctor. If that fails, you can appeal. Each step takes time. Meanwhile, your condition doesn't pause. That's why being passive here is costly. Let me show you exactly how the delays bite. Say your specialist orders an MRI for new neurological symptoms. The plan requests more notes. The office faxes records. A week passes. The plan denies for not meeting criteria. Your doctor schedules a peer-to-peer call. The earliest slot is 5 days out. You finally get approval for a lower-level scan first. The scan leads to the original MRI anyway, 2 weeks later. You've lost time, symptoms worsened, and now you're juggling extra visits and copays you didn't plan for. That cascade is common. Now here's where most people mess up. They assume the doctor's office will handle everything quickly. Many offices are swamped. Some are great at authorizations, others are. If you don't set expectations early, your file can sit in a pile, and when a denial hits, the clock starts on appeal timelines. Miss a deadline and you start over, that's money and health on the line. Here's the gotcha nobody tells you. In Medicare Advantage, more than 8 in 10 denied prior authorization decisions that are appealed get overturned, 81.7%. Translation: the initial no often becomes yes later. The delay is the point. You lose time, you rack up extra visits, some people just give up. Here's a practical way to reduce delays. When your doctor orders something that might need approval, ask 3 questions right away. Do we need prior authorization for this? What exact documentation and codes do you plan to submit? What's the expected timeline for approval? Then get the plan's written criteria. You're not being difficult, you're aligning everyone on the rules up front. If criteria require conservative treatment first, you want that documented now, not discovered after a denial. The shortcut nobody teaches is to pre-assemble your proof. Keep a simple folder, digital or paper, with recent clinic notes, imaging reports, medication history, and failed treatments. When the plan asks for evidence, you can help the office respond same day. Also, ask your doctor to include functional impacts that matter. Cannot walk more than 50 feet, night pain interfering with sleep, failed 8 weeks of PT. Criteria often hinge on these details. Let me give you a quick win you can try this week. Call your plan and ask for the prior authorization list for your conditions: imaging, infusions, specialty meds, home health, and rehab. Get it in writing or download it from the member portal. Share it with your doctor's office. Then ask the office who handles authorizations their typical turnaround time and the fastest way to reach them. A name and a direct line can save days. Now, once you nail the basics, here's the escalation path that separates beginners from pros. If a service is denied, immediately ask for the denial letter with the exact criteria not met, the plan's internal appeal levels and timelines, and a peer-to-peer review request. Have your doctor's office schedule a call within 48-72 hours. If your case is urgent, ask for an expedited review. Document every date and name in a simple log. If deadlines slip, you've got the record to push back. Here's the gotcha most people never hear. In Medicare Advantage, more than 8 in 10 denied prior authorization decisions that are appealed get overturned, 81.7%. That means many initial denials are reversed later after you've lost time. The system often says no first and fixes it on appeal. Common mistakes to avoid: waiting passively for the office to call you. Set check-ins every 48 hours until approved. Accepting not medically necessary without seeing the criteria. Ask for the page and line. Skipping the peer-to-peer review. These calls often resolve borderline cases. Ignoring step therapy rules. If a cheaper option must be tried first, document the trial or intolerance. Letting an authorization expire. Approvals have time windows. Confirm the service is booked within the valid dates. A micro story to drive this home. Last month, a viewer needed a lumbar MRI. The plan wanted 6 weeks of physical therapy first. Their doctor noted they'd already done 8 weeks in the spring with no relief and included pain scores and fall risk in the note. Peer-to-peer approved the MRI in 2 days. The difference was having the right documentation ready. If you remember nothing else, remember this: approvals favor the prepared. Clear criteria, tight documentation, fast follow-up. That's how you prevent delays from turning into complications and big bills. And when the bills do arrive, the shock usually isn't the premium. It's the copays, coinsurance, and repeat hits that stack fast. That's where we're going next. The out-of-pocket math no one explains until it's too late. The $50,000 risk, out-of-pocket exposure you didn't plan for. Here's where the math turns from annoying to dangerous. With Advantage, the premium often looks low, but the real money shows up as copays and coinsurance when care gets complex. Plans have a yearly out-of-pocket maximum for Part A and B services. Hit that and the plan pays 100% for the rest of the year. Sounds safe until you realize 3 things: the cap can be high, it resets every January, and not everything counts toward it. In other words, it's a trap that resets right in the middle of long treatments. That reset is the cruelest trap. You can spend thousands by December, then start over January 1 while you're still in treatment. Why this matters: serious events span months, often across a calendar year. Heart procedures, cancer treatment, joint replacement with complications, these aren't single visits. You can max the plan's in-network limit 1 year, then roll into January and start from zero while you're still in treatment. That's how families get crushed. They thought zero premium meant less risk. In practice, usage drives cost and the reset multiplies it. What counts? For Part A and B services, your plan's in-network copays and coinsurance count toward the cap. What often doesn't count is Part D drug spending, out-of-network charges in many HMOs, and any balance bills if you end up using a provider that's not contracted. If you're in a PPO with out-of-network benefits, there's usually a higher combined cap, meaning you can pay thousands more before protection kicks in. Let me show you exactly how the dollars stack. Say you have a heart event in October. You hit the ER copay, inpatient daily copays, cardiology follow-ups, imaging, and cardiac rehab. By December, you've reached the plan's in-network maximum. Relief, right? Then January 1 hits. You need a stent revision and more rehab. The counter resets. New deductibles or copays kick in, and you're paying again fast. If a key specialist is out of network or your plan requires prior auth that pushes you to a different facility, your costs jump again. Now add a common twist. An out-of-network specialist consult during a complication. In many HMO Advantage plans, that's simply not covered unless it's a true emergency and you're stabilized. Even in PPOs, out-of-network coinsurance can be steep, and the higher combined out-of-pocket limit applies. One consult, one imaging session, one anesthesiologist outside the network, and you're writing checks that don't move you closer to your in-network cap. Another budget buster nobody explains: travel for covered care. If the plan directs you to an in-network facility across town or in a different county, your transportation, caregiver time off work, and lodging for early morning procedures are on you. Those don't hit the plan's cap, but they hit your wallet. And when prior authorization delays push care later, you're stacking extra visits and copays you didn't plan for. Here's a simple scenario math to make it concrete. October, ER visit $100 $300 copay. 3-day admission with daily copays, say $300 $400 a day. Specialist visits $40 $60 each. Imaging $100 $400 per scan. Cardiac rehab sessions $20 $40 per visit times 36 sessions. You're already deep into the thousands, and those are conservative numbers. January, new hospitalization, more imaging, a procedure with a percentage coinsurance, more rehab. Reset means another sprint toward the cap. 2 years like this, and you can easily cross tens of thousands out of pocket even though your premium was low. Now here's where most people mess up. They don't know their plan's exact maximum and what applies to it. Don't guess. Quick win: pull your evidence of coverage and find the maximum out-of-pocket for in-network, and if you have a PPO, the combined in- and out-of-network number. Then list which services are subject to coinsurance versus flat copays. Percentage coinsurance on big-ticket items is where you accelerate toward the cap. A second quick win: run your known conditions through the benefits. If you have diabetes, look at endocrinology visit copays, labs, CGM supplies if billed under Part B, and step therapy for newer meds. If you have orthopedic issues, price advanced imaging, injections, surgery, anesthesia, DME, and rehab. If you're a snowbird, check how out-of-area care is handled outside emergencies. Common mistakes to avoid. Thinking zero premium means cheaper overall. Premium isn't the bill that hurts, usage is. Assuming your med costs help you reach the medical cap, Part D has separate rules. Ignoring out-of-network risk in HMOs, not covered, can mean 100% you. Forgetting the calendar reset, multi-year illnesses repeat the cost cycle. If you remember nothing else, remember this: your real risk isn't the monthly premium, it's the combination of copays, coinsurance, exclusions, and timing. Know your cap, know what counts, and plan for the reset. Next, how the marketing machine pushes you toward the plans most likely to trigger those costs. The marketing playbook: why good people choose bad plans. So how did we get here? The marketing is a machine. It's designed to make zero premium feel like zero risk and extras feel like protection. If you've ever watched a football game in October, you've seen the pitch: smiling seniors, bigger dental benefits, grocery cards, a friendly number to call. None of that explains networks, authorizations, or year-to-year changes. That gap is where bad decisions happen. Why this matters: when the message is simple and emotional and the rules are complex and hidden, most people choose based on the ad, not the evidence of coverage. Add time pressure and you'll default to the easiest yes. That's not a character flaw, it's human behavior under decision fatigue. Here's the core script. It's the same as Medicare but with extra benefits. Keep your doctor, premium, call now during open enrollment. Those lines blend federal branding with private plan features, and they anchor your brain on perks and price. Meanwhile, the real variables, provider networks, prior authorization lists, coinsurance on big-ticket items, barely get a sentence. The tactics are everywhere: door-to-door pitches at senior buildings, call centers that confirm your information before pivoting to a sale, TV ads implying government affiliation, high-pressure reminders of use it or lose it enrollment windows. And when you say you have a doctor you love, the agent checks a directory and says they're covered. Covered where, at which facility, under which NPI? Those details rarely make it into the conversation. Regulators have noticed. The FTC has issued warning letters to companies for deceptive Medicare Advantage marketing, misleading, free language, implying federal affiliation and burying limits. Senate investigators have documented high-pressure pitches in grocery stores and call centers that blur coverage details and downplay denials and delays. The thing most people miss is how freebies shape decisions. Vision, dental cleanings, hearing aids, OTC cards, these are vivid. You can picture using them, but they're small dollar items next to a hospitalization, an MRI, a skilled nursing stay, or an infusion therapy. Plans know this. The ad shows the perk. The fine print carries the risk. There's also the fear lever. Don't overpay for Medigap. Why spend hundreds a month? We'll cap your out-of-pocket. That sounds safer than it is because the cap resets yearly and often excludes drugs and out-of-network charges. But in a 2-minute call, that nuance doesn't land. You hear savings and a ceiling. You don't hear access limits and the path you'll walk to reach that ceiling. Here's the dirty truth. Your agent often earns more if you choose Advantage. Plans get extra rebate dollars, about $2,329 per enrollee, to fund perks and lower visible premiums. The plan does better when you use less care. The agent gets paid when you enroll. Everyone profits except you when you're sick. Here's the dirty truth. Your agent often earns more for placing you in Advantage, and the plan performs better when you use less care. Everyone at the table gets paid except you when you need treatment. Perks buy attention, restrictions control costs. That's the business model. A quick win: pre-commit your decision criteria before you talk to anyone. Write down 5 non-negotiables. Your doctors and hospitals by NPI, prior authorization needs for your known conditions, MOOP amounts in network and combined, travel needs, and coinsurance on expensive services. If a plan fails 2 or more, it's a no, no matter how shiny the extras look. And remember, the extras are funded by those rebate dollars. Perks buy attention, restrictions control costs. Another protective move: slow the conversation. If someone pressures you on the phone, say, "I don't enroll over the phone. Send me the evidence of coverage and your provider verification in writing." Real plans and real agents can back up claims. High-pressure callers will pivot or disappear. That tells you everything. Now here's where most people mess up. They compare perks, not coverage. They weigh a $2,000 dental card against a 20% coinsurance on a $10,000 procedure. They accept we cover your hospital and forget the surgeon, anesthesia, radiology, and rehab each have separate contracts. They assume no referral needed means no authorization needed. Different concepts. A micro story to make this stick. A couple called after switching during a grocery store sign-up. Their cardiologist was covered, but only at a satellite clinic that didn't do procedures. The cath lab they needed was at a different facility out of network. The plan offered an in-network alternative 40 miles away. Gas, time, and stress weren't in the brochure, but they were real costs. If you remember nothing else, remember this: marketing speaks in perks and premiums. Protection lives in networks, authorizations, and coinsurance. Perks make you feel good today. Access saves you tomorrow. Here's the checklist you can use before any pitch. Verify your doctors and hospitals by NPI for your exact plan. Ask for the prior authorization list tied to your conditions. Confirm MOOP for in-network and combined if PPO and what counts. Run your current drugs through the plan's tool and check tiers and restrictions. Get provider and cost confirmations in writing. No should be covered. Choose calmly, not on a call. Compare the right things and you'll avoid the trap. How to compare plans without getting tricked. Comparison only works if you compare the right things. The mistake most people make is lining up perks and premiums. You need a checklist that mirrors how care actually happens. Keep this simple and strict so you can disqualify fast and only dig deep on finalists. Start with providers and facilities. Why? Because access drives everything else. Make a list of your current doctors by full name and NPI, plus your preferred hospitals and outpatient centers. Call each office and ask, are you in network for exact plan name and plan ID next year? Confirm the NPI they bill under and the facilities where they have privileges. If any key provider can't say yes for that specific plan, stop evaluating that plan. Don't argue with maybe. Next, pull the plan's prior authorization list. Why this matters: authorizations control timing, and timing affects outcomes and cost. Look for your likely services: advanced imaging, infusions, injections, outpatient surgery, skilled nursing, home health, cardiac and cancer care. If these require prior auth, ask the plan for their clinical criteria and average turnaround times. Then ask your doctor's office if their workflow matches those timelines. If there's a mismatch, you'll feel it when you're sick. Now the money guardrail, MOOP, maximum out-of-pocket. Find the in-network cap, and if it's a PPO, the combined in- and out-of-network cap. What counts toward it? Part A and B services only, or other carve-outs? Coinsurance percentages on expensive items like outpatient surgery or chemo are the accelerators that drive you to the cap. If a plan hides these details or you can't find them in the evidence of coverage, disqualify it. Transparency is a feature. Drug coverage is its own trapdoor. Run your actual medications through the plan's formulary tool, not a generic list. Check tiers, quantity limits, prior authorization, and step therapy. If you use Part B drugs, infusions, some injectables, CGM supplies, confirm medical policy rules for those too. A premium won't matter if your biologic moves from Tier 3 to Tier 5 or requires step therapy you can't tolerate. Travel and split location living can break a plan fast. Ask, what counts as urgent versus emergency out of area? Do I have routine care access when I'm away? For snowbirds, verify local access in both locations by NPI, not just a brand name hospital. Many HMOs cover emergencies out of area but push routine and follow-up back home, which isn't practical after surgery. Here's a quick, practical workflow you can use in one sitting. Build a must-have list: named doctors with NPIs, named hospitals, key services you use, top 5 meds. Pre-screen 3 plans you're considering. If 2 must-haves fail on any plan, cut it immediately. For finalists, request written confirmation, provider participation by NPI, PA requirements for your conditions, MOOP numbers, and coinsurance for high-cost services. The thing most people miss is that a no referral needed plan can still be heavy on prior authorization. Those are different levers. If you rely on imaging, procedures, or specialty meds, the PA list matters more than the referral policy. Also, don't let dental and vision distract you. If you want those perks, price them separately. Often a standalone dental plan plus Original Medicare and Medigap outperforms a perk-heavy Advantage plan when you get sick. Common mistakes to avoid. Assuming the brand means uniform coverage. Each plan ID is its own contract. Trusting the online directory without calling. Directories lag, offices know tomorrow's contracts. Weighing extras over core access. Glasses don't offset a denied MRI. Ignoring coinsurance on big-ticket services. Percentages hurt more than flat copays. Quick wins you can do this week. Download the evidence of coverage for your top 2 plans and search for maximum out-of-pocket, coinsurance, and prior authorization. Call your 2 most critical specialists and confirm next year's network status by NPI for each finalist plan. Run your meds and save the formulary screenshots with tier, PA, and step therapy flags. If you remember nothing else, remember this: decide with your real doctors, real drugs, and real services, not with ads. Your must-haves protect you, the checklist keeps you honest. Disqualify fast and only compare plans that prove they'll support the care you actually need. Your exit paths: switching back to Original Medicare. Already enrolled and feeling boxed in? You're not stuck. You have exit windows, but timing and sequencing matter. If you remember nothing else, remember this: line up Original Medicare, Part D, and Medigap in the right order and know which window you're using before you make a move. Let me lay out your main doors. Door 1, the annual enrollment period, October 15 to December 7. During this window, you can drop your Advantage plan and switch back to Original Medicare starting January 1. You can also pick a standalone Part D drug plan. Door 2, the Medicare Advantage open enrollment period, January 1 to March 31. In that window, you can leave Advantage for Original Medicare and enroll in Part D for the first of the next month. Door 3, special enrollment periods triggered by specific life events, moving out of your planned service area, losing Medicaid, plan termination, and others. Door 4, the trial right safety valve if you joined an Advantage plan when you were first eligible for Medicare. You have up to 12 months to switch back to Original Medicare and buy certain Medigap plans without medical underwriting in many cases. Now here's where most people mess up. They drop Advantage and assume Medigap is guaranteed. Outside your initial Medigap open enrollment or a protected trial right, most states allow insurers to use medical underwriting. That means they can ask health questions, charge more, or decline. So you never cancel your Advantage plan until your Medigap application is approved and your new start date is locked. Sequence protects you. Here's a clean implementation flow. Step 1, choose your window. If it's October-December, plan for a January 1 effective date. If it's January-March, your effective date is the first of the month after you switch. Step 2, pre-apply for Medigap. Work with a broker who shops multiple carriers. Ask about underwriting criteria up front. Some carriers are more lenient for certain conditions. Get a tentative approval and effective date that matches your desired start. Step 3, pick your Part D plan based on your real medications, pharmacies, and any quantity limits. Do the formulary run, save screenshots, and enroll for the same effective date. Step 4, once Medigap is approved and Part D is set, contact your Advantage plan or enroll in Part D to trigger disenrollment. Enrollment in a standalone Part D while on Advantage will automatically move you back to Original Medicare on your chosen date. Quick win: if you're within your first 12 months on Advantage, use your trial right. Ask the Medigap carrier specifically about guaranteed issue rights for your situation and which plans qualify. Get it in writing. This right can save you from underwriting landmines. What if you're past 12 months? Underwriting is the hurdle. Prepare a health history summary, diagnoses, surgeries, medications, recent hospitalizations. Shop at least 3 carriers. If one declines, try the next. Criteria differ. Ask about effective date holds so your Advantage coverage continues until the Medigap start. If your health makes approval tough, don't panic. You can still switch to Original Medicare without Medigap, but know you'll be responsible for 20% under Part B with no cap. In that case, set a reminder to reapply for Medigap after any waiting periods required by the carrier. A few protective details most people skip. Align dates precisely. Your Medigap and Part D should start the same day Original Medicare resumes as primary. Confirm Part A and Part B are active. If you ever drop Part B, re-enroll before any switch. Save every confirmation letter and screenshot. Keep your Advantage card active until 11:59 p.m. the day before your new coverage starts. Common mistakes to avoid. Dropping Advantage before Medigap approval. Always lock Medigap first. Missing the Part D enrollment. Original Medicare without Part D triggers drug costs and potential late penalties later. Assuming a state guarantee you don't actually have. Rules vary. Ask your state health insurance assistance program for your state specifics. Letting a broker pick for you without a side-by-side in writing. Require a written comparison of premiums, underwriting status, rate histories, and household discounts. If you're overwhelmed, here's a 20-minute plan. Pick your window, call 2 Medigap carriers or a broker, run your meds on the Medicare Plan Finder for Part D, and set calendar reminders for application deadlines. The faster you line up approvals, the smoother your exit. The payoff? You trade managed access for broad access and you stabilize costs with Medigap. If switching isn't possible yet, don't worry, next we'll cover Medigap basics so you know exactly what you're aiming for and how to time it. Medigap basics, your freedom and your hurdles. Speaking of what you're aiming for, let's make Medigap clear and practical. Medigap sits next to Original Medicare. Original Medicare pays first, and Medigap fills most or all of the leftover Part A and Part B costs depending on the plan letter you choose. The big win is freedom, no networks. If a doctor or hospital accepts Medicare, you're good. That means nationwide access for routine and specialty care, second opinions, and centers of excellence without chasing in-network contracts. Why this matters? When you're facing a serious diagnosis, you want your doctor choice to be clinical, not contractual. With Medigap, there's no prior authorization for most Part B services. Your doctor orders, Medicare covers if it's medically necessary, Medigap picks up your share per your plan. That removes layers of delay and guesswork. And since Part B has no out-of-pocket cap, Medigap is the safety net that makes costs predictable. What are your options? Medigap plans are standardized by letter in most states. A B C D F G K L M N. So a Plan G from carrier X covers the same benefits as a Plan G from carrier Y. The differences are price, rate increases over time, underwriting rules, and customer service. Today, the most popular choice for new enrollees is Plan G. It covers the Part A hospital costs and almost all Part B costs, except the annual Part B deductible. Plan N can be cheaper but has small copays and doesn't cover some excess charges. Here's the hurdle most people don't see coming: underwriting. Outside your Medigap open enrollment, the 6 months after your Part B starts, or a specific guaranteed issue right like the first-year trial right out of Medicare Advantage, many states allow carriers to ask health questions. That can mean higher premiums, waiting periods for pre-existing conditions, or a denial. This is why timing your switch matters so much. You want to apply when your health profile is most favorable or when you have a protected right. Okay, so how do you apply without drama? Start by gathering your health history, diagnoses, surgeries, meds, recent hospital stays. Then shop multiple carriers for the same letter plan, at least 3. Ask about current premium, household or auto-pay discounts, rate increase history for your age and plan, and underwriting look-back rules. Some carriers are stricter on cardiac, cancer, or insulin use. Others are more flexible. Matching your history to a lenient carrier is the quiet advantage. There's a pricing nuance you should ask about: issue age versus attained age policies. Issue age sets your rate based on the age you are when you buy. It doesn't increase just because you get older, though it can rise for inflation or company-wide changes. Attained age usually starts lower but goes up as you age plus any company adjustments. Community rated sets the same base rate for everyone. None is automatically best, but you should understand how your premium is likely to move over 10 years, not just this year. Now the application steps. First, confirm your Part A and Part B effective dates. Second, pick your desired Medigap letter and shortlist carriers. Third, complete one application at a time. Don't stack multiple active applications unless a broker coordinates withdrawals, because approvals can collide. Fourth, align your effective date to match your return to Original Medicare and your Part D start. Fifth, get written confirmation of approval and policy number before you trigger disenrollment from Advantage. Dates are everything. Quick win you can do this week: call 2 Medigap carriers and ask, do you price this plan as issue age, attained age, or community? What was the average rate increase on Plan G for my age group over the last 3 years? If they won't answer clearly, move on. Transparency now prevents surprises later. Common mistakes to avoid: assuming you can get Medigap anytime with no questions. Underwriting is real in many states. Focusing only on today's lowest premium. A rock-bottom rate with steep annual increases can cost more long-term. Forgetting to pair Medigap with Part D. Medigap doesn't cover drugs. You still need a drug plan. Missing effective date alignment. One day of gap can mean claim headaches. If you're not sure whether to switch, do a quick stress test on your current plan. Could you see your preferred specialist next week at your chosen hospital without authorization hoops? If the answer is no, Medigap's value just went up. And if underwriting blocks you today, set a calendar to retry after any temporary health issues stabilize, and tighten your Advantage guardrails in the meantime. The plan stress test: will it protect you in a crisis? Before you change anything, stress test your plan, not for routine checkups for the messiest month of your life. The goal is simple: find hidden weaknesses now, not during a crisis. If you remember nothing else, remember this: a plan that barely works in routine care often breaks under pressure. Why this matters: worst-case events expose networks, authorizations, coinsurance, and timing all at once. If your plan fails under stress, you need a switch plan or guardrails ready. This takes 30-45 minutes and can save months of headaches. Here's the 10-question checklist. Give each a clean yes or no. 2 or more no's, your plan needs a change or serious guardrails. Doctors are your top 3 specialists and your primary care doctor in network by NPI for next year. Hospitals is your preferred hospital plus 1 backup in network, and do your specialists have admitting or procedure privileges there? Ancillary providers are anesthesia, radiology, pathology, and hospitalist groups at those hospitals in network for your exact plan. Prior authorization Do you have the plan's written criteria and typical turnaround times for imaging, outpatient surgery, SNF, home health, and infusions you're likely to need? Escalation path. Does your doctor's office have a named staffer who handles authorizations and peer-to-peer calls with direct contact info? Drugs. Have you run your real meds through the plan's tool, checked tiers, prior auth, quantity limits, and step therapy, and saved screenshots? MOOP clarity. Do you know your exact in-network MOOP, combined MOOP if PPO, and which high-cost services use percentage coinsurance? Travel. If you spend time in another state, do you have routine access there by NPI verification, not just emergency urgent coverage? Post-acute care. Are at least 2 skilled nursing facilities and 1 inpatient rehab you'd accept in-network, and do they require prior auth? Timelines. Do you know key appeal deadlines and have a simple log to track dates, names, and approvals? Now let's run a real scenario. Cancer workup plus surgery plus rehab plus a new specialist. Start on a Monday. Your primary care doctor orders abnormal labs and a CT. Question: does CT require prior auth? If yes, how many business days? If 3 to 5, can the office send notes same day? If the plan denies for criteria, can the peer-to-peer be scheduled within 72 hours? CT flags a mass. Your oncologist orders an MRI and a biopsy. Is the MRI facility in network, and does the radiology group bill under a contracted NPI? Biopsies scheduled at your chosen hospital. Are anesthesia and pathology covered? If pathology uses an out-of-network lab, what's your exposure? Surgery is set. The surgeon is in network, but is the facility a hospital outpatient department with higher coinsurance? Ask for the CPT codes and check your plan's coinsurance for that category. After surgery, you need skilled nursing. Is your first choice SNF in network and approved lengths realistic? If the plan limits days or requires weekly recertification, what happens on day 13? Complication hits. You need a subspecialist consult at a center your surgeon trusts. Are they in network? If not, will the plan authorize out of network for continuity of care or push you to an in-network alternative with a multi-week wait? That wait equals risk and repeat copays. Now score it. For each question or scenario piece that fails: network mismatch, unknown prior auth criteria, high coinsurance you can't stomach, no routine access when traveling, mark a fail. 2 fails, build guardrails in calendar, a switch window. 3 or more, start your exit plan now. Quick win: put all confirmations in a 1-page summary, doctors and NPIs, hospitals, PA contacts, MOOP numbers, and travel rules. Share it with your family and your doctors. In a crisis, nobody hunts portals. Common mistakes to avoid: testing for routine care instead of the worst month of your life. Crises reveal the truth. Accepting covered without NPI level confirmation. Ignoring post-acute authorization churn. Forgetting coinsurance on high-cost outpatient procedures. If you're on the fence after this, run one more scenario that fits your history: heart event with cardiac rehab or spine surgery with PT. If the plan slows or fragments care, that's your answer. If it passes cleanly, great, keep the summary current and set 6-month check-ins. If it fails, you're ready to switch or add guardrails in the very next window. Guardrails if you stay on Advantage. If switching isn't possible yet, don't wait for a crisis. Put guardrails in place so the plan works as well as it can when you need it. Think of this as your managed access toolkit. The goal is fewer surprises, faster approvals, and clear backups. Start with a high-risk service map. List the big items likely for you: advanced imaging, outpatient surgery, skilled nursing, home health, infusions or injections, cardiac or cancer care, and durable medical equipment. For each, call your plan and ask 3 things. Does it require prior authorization? What clinical criteria apply? And what's the typical turnaround time? Save the criteria PDFs. Then call your doctor's office and ask who handles authorizations, how they submit, portal, fax, and their normal turnaround. If there's a gap, close it now. Offer to provide notes and dates to speed submissions. Next, pre-verify facilities. For your preferred hospital, confirm. in-network status for your exact plan ID, the hospital outpatient department's billing category, and whether anesthesia, radiology, and pathology groups are in-network under the NPIs they bill. Do the same for a secondary hospital and 2 skilled nursing facilities. If a key ancillary group is out, ask the hospital if there's an in-network alternative team and note their names. This prevents the surprise anesthesiologist problem. Set a standing authorization cadence. When a doctor orders a service, get the CPT HCPCS codes and diagnosis codes. Ask the office the submission date, then create a 48-hour check-in rhythm. Day 2, confirm receipt. Day 4, request status. If pending beyond the plan's stated timeline, ask the office to flag expedited if clinically appropriate. If denied, request the specific criteria not met and schedule the peer-to-peer within 48-72 hours. Keep a simple log: date, who you spoke with, what was submitted, and next action. Authorizations expire, confirm validity windows, and reschedule before they lapse. Document medical necessity like a pro. Plans approved to criteria. Work with your doctor to make sure notes include failed conservative therapies, functional limits, can't walk 50 feet, can't sleep due to pain, safety risks, falls, and time-bound progression. For therapies with step requirements, log each step with dates and outcomes. When the plan asks, you're ready the same day. Build a provider contact sheet. 1 page with primary care and top specialists, NPIs, direct authorization contact at each office, preferred hospitals with admitting privileges, backup facilities, plan member services number, and the care management or case management line. Share it with a spouse or caregiver. In a crisis, you won't hunt for numbers. No urgent versus emergency rules. Urgent usually means care can't wait for a routine appointment but isn't immediately life-threatening. Emergency is life-threatening or severe risk. Ask your plan where you can go out of area for urgent care and which hospitals count for emergencies. If you travel or split time in 2 states, identify the nearest in-network urgent care and hospital in both places and save them in your phone. For plan procedures, don't assume travel coverage. Get the facility authorization first, in writing. Pre-verify high-risk meds. If you use specialty drugs under Part B or D, pull the plan's medical policy or formulary page, note prior authorization, step therapy, and site of care rules. Some plans push infusions from hospital to outpatient infusion centers. Confirm in-network sites now and book early slots to avoid delays. Use your plan's case management. Ask to be assigned a nurse case manager after a hospitalization or when starting complex therapy. A good case manager can nudge authorizations, coordinate transitions, and clarify benefits. If the first isn't responsive, politely request reassignment. Create an authorization tracker. A simple 2-column sheet works: what's ordered and where it is in the pipeline. Add due dates and escalation points. If an office is slow, ask if a different staffer handles urgent cases or schedule a brief call with the practice manager to agree on a turnaround plan for your chart. Common mistakes to avoid. Assuming the plan will call you when policies change. They may mail notices, but offices miss them. Ask your providers each fall about next year's contracts. Relying only on the plan directory. Always confirm by NPI with the provider's billing department. Letting denials sit. Appeal windows are short, treat them like deadlines. Forgetting post-acute care. Pre-identify in-network SNFs and confirm transport coverage, days allowed, and recert requirements. Quick win you can do today. Spend 30 minutes building your contact sheet and authorization log template, confirm your nearest in-network hospital, and email your top specialist's office asking for their authorization point person and best contact method. That one email can shave days off your next approval. The hidden costs you don't see on the brochure. There's one cost advantage brochures never price in: your time and stress. When care gets complicated, the hidden taxes are hours on hold, rescheduling after denials, driving farther for in-network care, and asking family to miss work to help. None of that shows up in a premium chart, but it drains you and your caregivers fast. Why this matters? Delays aren't just annoying, they change outcomes and stack bills. Every week you wait for approval can mean extra visits, duplicated tests, ER detours, and lost income for the person helping you. And when you're tired, details slip, deadlines, forms, names, which creates more delays. That's a spiral you can prevent if you set up simple systems now. Let's make the hidden workload visible. First, time on hold. Authorizations, referrals, and appeals each involve different phone trees. You repeat your ID, dates of service, CPT codes, and facility names countless times. If you don't track them, you end up calling back to retell the story. Second, appointment churn. A denial the day before a scan forces a cancel, a doctor addendum, a peer-to-peer call, and a rebook. That's 3 to 5 contacts per service. Third, travel. If your plan's nearest approved facility is across town or in another county, that's fuel, parking, and sometimes hotel nights for early procedures. Fourth, caregiver costs. Someone needs to drive, wait, and advocate. Unpaid time off is a real hit. Health costs also hide in timing. A postponed diagnostic can mean a bigger surgery later. An extra week of uncontrolled pain can mean lost mobility and longer rehab. If post-acute care is limited or reauthorized in short chunks, you or your family become the default nursing staff at home. That's bathing, wound care, medication logs, work most people never plan to do. Money sneaks in through repetition. Every rescheduled specialist visit carries another copay. Each try this first step therapy adds pharmacy trips and check-ins. If an out-of-network lab processes a specimen, you can get a bill that doesn't count toward your medical cap. And when a plan pushes you to a different site of care, hospital outpatient instead of ambulatory surgery, the coinsurance percentage often jumps. Now here's where most people mess up. They keep it all in their head. In a crisis, memory fails, dates blur, names vanish, and appeal windows close. You need a simple external brain. A one binder or one folder system works wonders. Quick win, set up 3 sections: contacts, authorizations, and appointments. In contacts, list plan numbers, your ID, case management line, and each provider's direct authorization person and NPI. In authorizations, keep orders, CPT, HCPCS codes, diagnosis codes, criteria PDFs, submission dates, and status. In appointments, track what's scheduled, what requires prep, and who's driving. One glance tells you what's pending and who to call. Delegate early, pick a primary helper and a backup. Share the binder or a shared online folder. Assign roles. One person handles plan calls and logs names, another manages provider portals and uploads notes. You focus on medical decisions and symptom tracking. Delegation isn't a luxury, it shortens delays because calls and uploads happen the same day. Use templates to reduce friction. Draft a standard message for provider portals. We believe Service X meets criteria because failed PT since date, functional limits details, safety risks details. Please submit with CPT codes and request expedited review due to reason. Copy-paste, adjust details, send. For plan calls, use a script. Confirm receipt of request number, ID, date submitted, X, clinical criteria applied, doc name, and expected decision date. Consistency speeds answers. Build a travel plan if care shifts sites. Identify parking locations, arrival times, and check-in floors. Line up a rides list with 2 backups. Note which facilities validate parking and which don't. If the plan prefers a distant infusion center, ask for clustered scheduling to reduce trips and confirm that the exact center's NPI is in network. Protect your energy with a 15-minute rule. Any task that threatens to sprawl, hold music, portal errors, insurance loops, set a timer. At 15 minutes, escalate or switch channels, request a callback, send a written message through the portal, or email the office contact. Momentum beats marathon holds. Common mistakes to avoid. Calling without codes. Always have CPT, HCPCS, and diagnosis codes on hand. Letting denials age. Appeal windows close fast, request the criteria the same day. Forgetting to confirm ancillary providers. An out-of-network anesthesiologist can blow up a bill. Skipping case management. Ask your plan for a nurse case manager after a hospital stay or when starting complex therapy. If you remember nothing else, remember this: organization shrinks hidden costs. A binder, a contact sheet, and 2 helpers turn chaotic weeks into a manageable checklist. That's how you protect your money, your time, and your health while you line up your longer-term plan. The 3-step protection plan. Let's turn all of this into a simple plan you can finish in one afternoon. 3 steps: audit, decide, act. Do this once, keep it updated twice a year, and you'll avoid 90% of the traps we've covered. Step 1 is audit. You're stress testing your current plan with real names, real meds, and real services. Start with providers, list your primary care, top specialists, and preferred hospitals. Verify each by NPI for your exact plan ID. Next, pull your plan's prior authorization list and the clinical criteria for imaging, outpatient surgery, SNF, home health, cancer, and cardiac care, and any specialty drugs you use. Then find your MOOP, both in network and combined if you're in a PPO, and flag which services use percentage coinsurance. Finally, run your actual medications through the formulary tool and save screenshots for tier, quantity limits, prior auth, and step therapy. Put everything into a one-page summary: NPIs, facilities, PA contacts and timelines, MOOP numbers, coinsurance highlights, travel rules. That's your baseline. Quick win: schedule a 30-minute calendar block this week to do the provider verification and MOOP hunt. Those two alone expose most hidden risks. If you split time in 2 states, add a second 15-minute block to confirm out-of-area access by NPI, not just brand names. Now step 2, decide. You're setting rules ahead of time so decisions are calm, not crisis-driven. Write down your switch criteria. For example, if 2 or more specialists can't confirm in network by NPI for next year, switch. If prior authorization delays exceed the plan's stated timeline twice on high-risk services, switch. If coinsurance on a plan procedure pushes you to 50% of MOOP before April, switch. Add a travel rule. If routine care isn't available near your second home, switch or set a deadline to apply for Medigap. Then choose your enrollment window: annual enrollment, Oct 15, Dec 7, Medicare Advantage, open enrollment Jan 1, Mar 31, or a special enrollment you expect. Put reminders 30, 14, and 7 days before the window opens. Decision fatigue is real. Calendars beat willpower. Also, decide your backup if underwriting blocks Medigap this season. Maybe you tighten Advantage guardrails for 6 months and retry Medigap after a surgery heals or a look-back period ends. The point is to pre-choose your plan B so you're not scrambling later. Step 3, act. If your criteria say stay on Advantage, implement guardrails now: authorization cadence, provider contact sheet, facility pre-verification, and case management enrollment. If your criteria say switch, line up Original Medicare, Part D, and Medigap in sequence. First, pre-apply for Medigap with 2 or 3 carriers. Same plan letter, compare pricing method, issue age, attained age, community, and recent rate histories. If you qualify for a guaranteed issue right, like the first-year trial right, confirm it in writing and ask which plans it applies to. Secure Medigap approval and an effective date. Second, choose a Part D plan using your real meds in pharmacies, save the formulary confirmations, and set the same effective date. Third, trigger the move. During your chosen window, enroll in the Part D plan or contact your Advantage plan to disenroll. Enrollment in a standalone Part D while on Advantage auto-returns you to Original Medicare on the effective date. Keep coverage continuous, no gaps. Confirm Part B is active and aligned. If underwriting is tough, don't cancel Advantage until you have Medigap approval. If you must move back to Original Medicare without Medigap, budget for 20% coinsurance on Part B services and set a reminder to reapply for Medigap when your health profile improves or a new window opens in your state. Common mistakes to avoid. Treating the audit as a directory skim. Always verify by NPI and facility privileges. Letting perks sway. Step 2. Your criteria should be access, authorization timelines, and coinsurance risk, nothing else. Misaligning effective dates. Medigap, Part D, and Original Medicare should start the same day. Dropping Advantage before Medigap approval. Sequence protects you. If you remember nothing else, remember this: audit exposes the risk, decide sets the trigger, act locks in access. 30 focused minutes this week starts the process. Your future self will thank you when life throws a curveball and your plan just works. The agent's blind spot, incentives, and what to ask. Before you make any final decision, you need to understand the sales incentives shaping what you hear. Most agents are not villains, but the pay structure nudges recommendations. Plans often pay higher first-year commissions on Medicare Advantage enrollments and separate renewals each year you stay. Some agencies add bonuses for hitting enrollment targets with certain carriers. That doesn't make advice automatically bad, but it does mean you should separate guidance from compensation. Why this matters? Incentives tilt conversations toward what's easy to sell today, not what protects you during a crisis next spring. If the plan pays more for new signups, you'll hear more about perks and less about authorizations, coinsurance, and provider NPIs. Knowing this lets you ask smarter questions and insist on written proof. Here's the shortcut nobody teaches: force transparency. Say, before we talk plans, please disclose your compensation, which carriers pay you, and is there any bonus for enrolling me in a specific plan? A good agent won't flinch. If they dodge, that's your signal. Next, ask for apples-to-apples comparisons. Show me in writing my total cost if I need a hospitalization and outpatient surgery and 6 months of specialty visits next year. Include coinsurance, daily copays, prior authorization requirements, and the plan's MOOP. Know that watchdogs have flagged abuses. The FTC has issued warning letters to companies for deceptive Medicare Advantage marketing, misleading free claims, and confusion about government affiliation. Senate investigators have documented high-pressure pitches, think grocery store signups and call centers that blur coverage details. Use that context to justify your demand for proof on NPIs, prior auth rules, and costs in writing. The thing most people miss is how vague phrases hide real risk. "Don't worry, it's covered" means nothing without where and under which NPI. "Your doctor is in" might only mean a clinic location that can't do procedures. So pin it down. Ask the agent to verify in writing the exact NPIs for your primary care, top specialists, and hospitals for the specific plan ID and upcoming plan year. Require screenshots or emails from provider billing offices. If they balk, pause the conversation. Here's a practical set of questions that protect you. Compensation: what's your commission structure for each plan you're recommending? Any carrier bonuses or overrides I should know about? Access: verify my doctors and hospitals by NPI and site of service for next year's plan ID. Are anesthesia, radiology, and pathology groups at those facilities in network? Prior authorization: list the services tied to prior auth for my conditions and provide the clinical policy links. What are average approval timelines? Costs: what are the in-network and combined MOOPs, and which services use coinsurance versus copays? Show me CPT category coinsurance for imaging, outpatient surgery, chemo, and rehab. Drugs: run my actual meds through the formulary. Note tiers, prior auth, quantity limits, and step therapy. Travel: what's routine access out of area? Confirm urgent versus emergency coverage rules. Now, once you nail that, push for documentation. Say, send me a side-by-side comparison for my top 2 plans plus Original Medicare with Medigap G and a Part D option. Include premiums, expected out-of-pocket for my scenario, prior auth notes, and provider confirmations. Paper beats promises. If the agent suggests switching plans mid-year as a fix, ask, under which election period and with what consequences? Show me the rule. Common mistakes to avoid. Letting the agent drive the agenda. You lead with your 5 non-negotiables. Accepting directory checks as final. Directories lag, billing offices no contract status. Comparing only premiums and perks. Coinsurance on big-ticket services is the real lever. Skipping denial rates and appeals info. Ask, what's this carrier's reputation for prior auth denials and turnaround? Any public reports or policy updates? Here's a quick win that flips the power dynamic. Ask one question in writing. If I need X next year, 1 hospitalization, 1 outpatient surgery, advanced imaging, and 10 specialist visits, how much will I pay total under this plan? A serious agent will build the estimate and cite the evidence of coverage. A flimsy pitch will fall apart. Either way, you've learned what you need. One more protective move: involve your doctor's office. Forward the plan's prior auth criteria and ask, can your team meet these timelines? Any known issues with this carrier? Front desks see the daily friction. Their answers are gold. If you remember nothing else, remember this: incentives shape scripts. Written proofs beat smooth talk. When agents know you'll verify NPIs, prior auth policies, and coinsurance math, the conversation shifts from perks to protection, exactly where it belongs. Here's the takeaway: choose access and predictability over perks, because networks, prior authorization, and coinsurance, not premiums, decide your real costs and outcomes. If this helped, grab the 1-page stress test and 3-step checklist linked below, then watch my Medigap options and pricing pitfalls video next to lock in your safety net. Subscribe for more clear, no-spin guides that protect your care and your wallet. Frequently asked but what if scenarios. Snowbirds and travel first. Can you live in 2 states on Advantage? Usually not smoothly. Most HMOs only cover emergencies out of area and push routine care back home. PPOs may allow some out-of-network at higher cost and often still require prior auth. Practical move: verify in both locations by NPI for the exact plan ID. Ask what counts as urgent versus emergency, and where you can get follow-up after a hospitalization away from home. If you want routine care in both places without network drama, Original Medicare plus Medigap is the clean path. And if you must stay on Advantage, identify an in-network urgent care and hospital in both locations and save their NPIs now. Chronic conditions: dialysis, cancer centers, specialty drugs. Advantage plans tightly manage these. Dialysis often requires contracted centers. Switching mid-course can be disruptive. Major cancer centers may be out of network or limited access, and Part B oncology drugs can face step therapy or site of care rules. Your move: before enrollment, ask for medical policies for your exact regimens, infusions, injections, imaging cadence, and average prior auth timelines. Have your oncologist's office sanity check whether they can meet those timelines with that carrier. If you rely on a specific center of excellence, verify NPI-level participation for the facility and physician groups, including pathology and radiology. If those can't be confirmed in writing, don't enroll. Rural access: Advantage networks can be thin in rural counties. That means longer drives for in-network hospitals, fewer specialists, and more denials of out-of-network claims. Do a nearest in-network reality check. Name the closest hospital, 2 skilled nursing facilities, the imaging center, and your essential specialists. Confirm each by NPI. If the travel time is unsafe for winter or emergencies, that's a red flag. Under Original Medicare with Medigap, most rural hospitals and specialists that accept Medicare are accessible without network rules. If you stay on Advantage, set a travel plan, routes, backup facilities, and how to request urgent out-of-area approval. Late switch risks and underwriting. If you're past your Medigap open enrollment and not in your first year of Advantage, many states allow underwriting for Medigap. You can switch from Advantage back to Original Medicare during the allowed windows, but Medigap isn't guaranteed unless your state has special protections. Action step: before you drop Advantage, pre-apply for Medigap and get the approval and start date in writing. If declined, ask your state health insurance assistance program about state-specific rights, birthday rules, or trial rights you may qualify for. If you must return to Original Medicare without Medigap, budget for 20% under Part B and reapply when health stabilizes or a state window opens. Drugs that move the needle. What if a Part D plan drops your med or adds step therapy? Run your current meds every year during open enrollment and save the screens. If a key drug changes tiers or restrictions, switch Part D plans if you're on Original Medicare, or consider a different Advantage plan that handles your meds better. For Part B drugs, ask for policy documents. If a plan forces step therapy you can't tolerate, work with your physician on exception requests showing failed alternatives and clinical risk. Moving mid-year. If you relocate out of your plan's service area, you get a special enrollment period. Use it to pick a new Advantage plan in your new area or switch to Original Medicare. Again, line up Medigap first if that's your destination, because underwriting may apply unless you have a guaranteed issue right. Keep coverage continuous by aligning effective dates. Caregiver Playbook. Who calls whom when things get complicated? Designate a primary and a backup caregiver with permission on file at your plan and providers. Build a simple escalation ladder: office authorization contact, practice manager, plan member services, plan appeals, and a nurse case manager. Use a log: date, person, number, request ID, promise timeline, next step. Keep orders and codes handy. If an authorization stalls, request the clinical criteria in writing and schedule a peer-to-peer within 48-72 hours. If the first peer review fails, ask about a second-level review. Emergency versus urgent confusion. If you're traveling and land in an ER, stabilize first. Keep all documents. Before discharge, ask the plan about covered follow-up where you are. Many HMOs require routine follow-up at home. If that's unsafe due to surgery recovery, ask for a temporary coverage exception and get the approval in writing. For urgent care out of area, confirm which centers are recognized and how claims should be billed. What if I just want the perks? Price perks separately. A standalone dental plan plus Original Medicare and Medigap often beats a perk-heavy Advantage plan once serious care starts. If you keep Advantage for perks, at least install the guardrails, prior auth cadence, provider NPIs, facility pre-verification, and a case manager. You're ready, pull your plan documents, run the stress test, and start your audit today.